Introduction. The typical signs of an eating disorder include obsessive, compulsive, and impulsive patterns of behavior related to food or weight. Diets are a typical starting point for people with eating disorders, but the underlying problems are far more complex than difficulties with food and self-image. Most times, individuals who battle with eating disorders also deal with poor self-esteem, depression, anxiety, or other mental health issues. The causes of eating disorders include genetic, biological, psychological, and cultural factors. Anorexia nervosa, bulimia nervosa, and binge eating disorder, BED, are the three primary types of eating disorders recognized by the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, text revision, DSM-4TR. In this book, we will go deep and look at everything you need to know about eating disorders and how to recover from it. Chapter 1. Diagnostic Criteria for Eating Disorders. The DSM-4TR diagnostic criteria for anorexia nervosa include refusing to maintain a body weight at or above a minimally normal weight for one's age and height. Extreme concern about gaining weight while being at a healthy weight already. The person has engaged in binge eating and purging behaviors, such as self-induced vomiting or inappropriate use of laxatives, diuretics, or enemas, often during the current episode of anorexia nervosa. Frequent episodes of binge eating are included as diagnostic criteria for bulimia nervosa in the DSM-4TR. During a binge eating episode, both of the following are present. 1. A person is considered to be binge eating when they eat more than a usual person would in a certain amount of time. 2. You have loss of control over your eating patterns throughout the episode. You don't know how much or how often you're eating. Binge eating and other inappropriate behaviors towards food occurs at least twice per week on average during a 3-month period. The purging type of bulimia nervosa includes behaviors like self-inflicted vomiting and abusing laxatives, diuretics, or enemas. The DSM-4 also mentions another type of eating disorder known as eating disorders not otherwise specified, EDNOS. This category is for eating disorders that do not meet the requirements for any other form of eating disorder. This group of patients may have more severe forms of anorexia or bulimia, or they may be at a younger stage of the illness. The following signs are indicators. 1. A woman satisfies all the criteria for anorexia nervosa if she does not have irregular menstrual bleeding. 2. Except for the fact that their current weight is within the normal range, the person satisfies all the diagnostic criteria for anorexia nervosa. 3. All of the requirements for bulimia nervosa are met, with the exception of binge eating happening more often than twice per week and using the wrong coping mechanisms for more than 3 months. 4. Regular use of unhealthy compensatory behaviors such as pushing oneself to vomit after eating normal-sized meals. 5. Large portions of food are repeatedly chewed and then spat out without being fully digested. 6. Binge eating disorder is characterized by recurrent bouts of binge eating without the typical concomitant use of hazardous bulimia nervosa coping strategies. DSM-4TR criteria for binge eating disorder. Repeated binge eating episodes. During a binge eating episode, both of the following are present. 1. Eating more food in a short amount of time, say, during the course of any 2-hour period, than is reasonable to expect the normal individual to under similar circumstances. 2. You have a loss of control over your eating patterns throughout the episode. You don't know how much or how often you're eating. A minimum of 3 of the following are associated with binge eating. 1. Eating food in a frantic manner. 2. Consuming food till one gets uncomfortable from overeating. 3. Eating a lot of food, even when you're not hungry. 4. Eating in secret because of guilt for having too much hunger. 5. You could experience regret, sadness, and embarrassment after overeating. What distinguishes bulimia nervosa from anorexia nervosa? Many individuals who battle either bulimia or anorexia also battle the other. Bulimia affects around half of those who battle with anorexia. An obsessive obsession with one's physical appearance is a feature of both diseases. Calorie restriction, binging and purging via vomiting or laxatives, and excessive exercise in an effort to lose weight are behavior associated with both disorders. The important difference is that in order to be diagnosed with anorexia, a postmenopausal female must also have amenorrhea and be underweight, weight 15% below expected weight for age and height. Despite having amenorrhea and losing weight, many persons who binge and purge, as well as those who do not binge but do purge, are mistakenly classified as having bulimia. These persons have the typical signs of purging and binge eating disorders. The relationship between binge eating and purging. Binge eating is often cited with the other two main eating disorders, bulimia and anorexia, even though the DSM-4 does not expressly include it as an eating disorder. It is still up for dispute and research as to whether or not this disease, previously known as compulsive overeating, should be broken off into its own diagnostic category or remain in the category of EDNOS, where it is now classified in the DSM-4. The fact that you binge eat sometimes, however, does not always mean that you have this disorder. Many individuals sometimes experience what they consider to be binges, but these episodes do not meet the requirements for BED. It is important to understand what a binge truly is and the other symptoms of BED because, while some anorexic patients claim to binge, when questioned for details, they refer to a few cookies, any fattening food, or eating late at night as a binge. Is it possible for individuals with normal weight to have an eating disorder? It's a widespread misperception that individuals with eating problems are either gravely overweight or dangerously underweight. These two traits may not necessarily point to an underlying disturbed relationship with eating. The specific weight of a person is influenced by several things. The only eating disorder with a stated weight requirement is anorexia nervosa. However, both bulimia and anorexia include obsession with body image and associated weight control behavior. You have this condition if your weight is 15% below what it should be for your height and age. For the diagnosis of bulimia nervosa, binge eating disorder, or eating disorder not otherwise specified, weight is not a factor. If I purge after every meal but never binge, do I have bulimia? Some people choose to eliminate their meals in some manner rather than binge eating. To be labeled as having bulimia, a person must binge eat followed by purging or making other efforts to curb their hunger. While some people who purge also meet the requirements for anorexia of the binge/purge kind, some people are more appropriately diagnosed with EDNOS. Does the fact that I have an EDNOS diagnosis from my doctor mean that my eating disorder is minor? People with an EDNOS diagnosis often believe that they have a lesser type of bulimia or anorexia. Sometimes, but not always, this is true. People with severe chronic eating disorders, or those who have serious medical problems as a consequence of their eating disorders, are more likely to be diagnosed with EDNOS. Chapter 2. A brief history of eating disorders. Eating disorders haven't been an unusual phenomenon throughout history. The widespread use of vomitoriums, structures created specifically to go vomit before binge eating, shows that neither the ancient Greeks nor the Romans of Caesar's time viewed binging and purging as a medical condition. Even while ancient Egyptians encouraged self-induced vomiting as a healthy habit, it was not seen as a disorder. And neither was bulimia known to be a disorder. Before the release of the Diagnostic and Statistical Manual of Mental Disorders in 1987, the present form of bulimia nervosa was not acknowledged as a unique disorder. Due to their fasting regimens, several saintly women from the 13th century were declared saints, which may have marked the beginning of a tendency that we now know as anorexia. These holy individuals are referred to as holy anorexics, and they underwent great self-denial in their quest for holiness and lost at least 25% of their body weight. It was believed that several of these women had binge and restrictive eating habits. Modern anorexics will find this to be all too familiar, with the main exception being that the emphasis is now on calorie restriction and less exercise. The self-destructive behavior that were formerly praised and admired for the holy anorexics of medieval times have now been adopted by people with anorexia nervosa. Richard Morton of London first properly described anorexia nervosa in medical literature in 1689. He saw that the illness was distinguished by excessive lethargy and a lack of appetite that didn't seem to be brought on by medical symptoms, but rather by depression and stress. Morton is renowned for his description of a patient as a skeleton clad only with skin. Anorexia nervosa was first coined by psychiatrist and researcher Antonia Gull to define the condition as having a morbo morbis. The majority of individuals think that binge eating is a new eating disorder. It seems to have existed for a very long time, but was probably not classified as such because of its resemblance to obesity. It may have been challenging to identify the fraction of obese or overweight persons who also have the psychological problem of binge eating, since the general population views obesity as a medical disease. Eating disorders were misunderstood for the overwhelming duration of their existence. Scientists didn't start to take psychological and emotional elements into account in self-starvation cases until the 1930s. How common are eating disorders? It is uncertain how common eating disorders really are. Surveys conducted in communities and in treatment facilities have attempted to determine the prevalence of eating disorders, but the results have been ambiguous. Since there are so many different ways to look at these diseases, the real prevalence is probably underreported. The prevalence of the illness varies by age group as well. Despite being the least common eating disorder, anorexia nervosa affects a disproportionately high percentage of young women. Multiple publications provide contradicting statistics about the prevalence of eating disorders. According to some sources, bulimia affects between 1.1% and 4.2% of persons, while anorexia affects between 0.5% and 3.7% of women. In both boys and girls, between 2 and 5% have BED, according to the Eating Disorders Coalition website. It seems that EDNOs would have a far larger population than binge eating and bulimia. To accurately determine EDNO's frequency, however, not enough study has been done in the field. Even discussions regarding the prevalence rates of eating disorders, which often focus on bulimia and anorexia, did not include BED until recently. Are these disorders more common among adolescents? According to research, eating disorder sufferers among teens are disproportionately female. However, eating disorders affect individuals of various ages. According to a study, the number of women over the age of 40 who were admitted to residential treatment facilities for eating disorders increased by 400% between 2005 and 2006 in the U.S. Not only in the United States, but all throughout the globe, eating disorders in young children are on the increase. Experts have seen kids as young as 10 hospitalized with anorexia and bulimia. Many professionals in the field think that the worrisome rise in the frequency of hospital admissions of kids as young as 4 and 5 years old displaying signs of anorexia and bulimia is caused by the rising popularity of measurements like body fat report cards in schools. A study detailed in the September 2006 edition of the International Journal of Eating Disorders found a significant rise in the number of patients under the age of 14 who were admitted, from 5 in 2003 to 25 in 2005. Can males have eating disorders? 1 in 6 instances of anorexia or bulimia occur in males, and BED is approximately equally prevalent in men and women, according to a Canadian research. Men are not as likely to detect the signs of an eating disorder and seek treatment for it, which could be the reason males seem to have a lower percentage according to statistics. Chapter 3. Additional conditions and problems that people with anorexia or bulimia often battle with. Common co-occurring illnesses in those with anorexia and bulimia include anxiety disorders, depression, body image problems, and personality disorders like borderline personality disorder. Drug addiction issues are linked to bulimia and the anorexic binge purge type, but OCD and social anxiety are more prevalent in anorexics. These additional disorders must present themselves in ways unrelated to food or weight in order to be appropriately identified as distinct from the eating disorder. If someone has OCD, they will also exhibit obsessions and compulsions that have nothing to do with eating or weight, including frequently washing their hands. If a person has body dysmorphic disorder, it will show itself in a variety of ways. A young man with anorexia nervosa and body dysmorphic disorder I once encountered several years ago was fascinated with many other parts of his physical appearance, in addition to his weight and calorie consumption. He had issues with his freckles, which he thought were terrible. This guy was so afraid of getting freckles that he would not leave the house unless he was fully clothed, even with gloves. He once burned his skin while attempting to eradicate his freckles. It's also important to understand that OCD, or any other mental condition, is not a diagnostic indicator of an eating problem. People who show signs of both an eating disorder and OCD should get help for both illnesses. It may be difficult to distinguish between anorexia and obsessive-compulsive disorder when a person has symptoms that are similar to both disorders. However, in addition to symptoms connected to food, eating habits, and weight, OCD is often accompanied by additional symptoms. The majority of OCD sufferers discover that gaining weight and modifying their nutrition completely or significantly lowers their symptoms. True anorexic OCD patients often claim that their OCD symptoms started before their eating disorder was recognized. OCD symptoms include engaging in ritualistic hand washing or repetitive checking habits, such as making sure all the doors were secured before developing an eating disorder. OCD treatment is also necessary if these behaviors were present prior to the eating disorder and persisted after healing. True OCD may be difficult to identify, but on occasion, a patient's history makes it clear that both OCD and an eating problem are present and that both disorders need to be treated at the same time. The hazards of eating disorders. Eating disorders have a broad variety of possible health consequences. Both a lack of food or sustenance and efforts to purge the body of harmful chemicals by abusing laxatives excessively or by vomiting may cause serious health problems. Binge eating may also result in unhealthy weight gain. Some common medical conditions that people with eating disorders often face are discussed below. Acid reflux. Due to a malfunctioning valve that controls stomach acid, this condition is common in people with eating disorders, particularly bulimics. Acid and digestive enzymes from the stomach may combine with anything in the esophagus and go all the way back to the mouth. Emergency medical assistance should be sought if reflux symptoms are severe enough to make it impossible to eat. Barrett's esophagus is a serious condition that affects the esophageal cells and, if ignored, may develop into cancer. Low hormone levels from an inadequate diet lead to amenorrhea, the absence of menstruation, which commonly, but not always, results in weight loss and fat loss. Amenorrhea, which is the lack of menstruation and bone density decrease, is caused by eating disorders. Loss of bone density is one of the most serious and sometimes permanent side effects of eating disorders, particularly anorexia nervosa. Over time, amenorrhea patients' bone density declines, which may result in disorders including osteopenia, below normal bone mass, and osteoporosis, severe bone loss. Because of the condition, osteoporotic bones are porous and easily break. Skin bruising, which may be brought on by low blood pressure, severe weight loss, a lack of platelets, a deficiency in vitamins and minerals, as well as the aforementioned conditions. Cardiovascular problems, slow or irregular heartbeat, arrhythmias, angina, and heart attack are only one of the many eating disorder-related problems that might cause heart problems or a heart attack. Sudden cardiac arrest is one of the leading causes of death in anorexia nervosa, and some experts think it could be the same for bulimia. Electrolyte imbalances, dehydration, low blood pressure, severe orthostatic hypotension, and an exceptionally slow heart rhythm are some of the most hazardous problems for the heart which can be caused by eating disorders. Being overweight may lead to hormonal imbalances, an increase in cholesterol levels, and an accumulation of fat around the heart muscle. Dehydration results from the loss of body fluids brought on by vomiting, excessive laxative or diuretic usage, or an insufficient intake of fluids. More severe diseases including renal failure, heart failure, seizures, brain damage, and even death might develop as a result of these symptoms. Dental problems, including severe decay, gum disease, and tooth enamel loss brought on by vomiting stomach acids. Teeth decalcification may be brought on by a hormone imbalance, a calcium deficiency, or a lack of vitamin D due to eating disorders. Malnutrition, dehydration, vitamin and mineral deficiencies, and inadequate nutrition all have a role in hair loss and dry skin, hair, and nails. Also, addiction to laxatives or diuretics may cause edema, a swelling of the soft tissues. Disturbances in electrolyte balance. Electrolytes are essential for the movement of nutrients and oxygen to the body cells, as well as the transmission of nerve, muscle, and organ impulses. Cardiovascular arrest brought on by an electrolyte imbalance may be catastrophic for those with eating problems. Hypokalemia, abnormally low potassium levels, and metabolic alkalosis, high bicarbonate levels, are common in patients who vomit or use diuretics to purge, both of which may be deadly. Hypokalemia may also result in metabolic alkalosis, which may have adverse repercussions such as irregular cardiac rhythm, seizures, and arrhythmias. Most individuals with eating disorders experience intestinal discomfort. The rate of bowel movement might increase or decrease. Not eating enough or quitting the use of laxatives may cause severe constipation. Internal bleeding from the digestive system and stomach rupture have both been connected to binging. Low blood sugar, or hypoglycemia, may lead to neurological and mental impairment, as well as be a sign of liver or kidney problems. High blood sugar, or hyperglycemia, may have the opposite impact. Obesity and bad eating habits may cause hyperglycemia, or high blood sugar brought on by reduced insulin production, which can result in diabetes. Infertility, the loss of a woman's monthly cycle, hormone imbalances, malnutrition, or vitamin shortages may all make it more difficult for her to conceive a child. At least one study has connected polycystic ovarian syndrome to a propensity for binge eating. Iron deficiency anemia, which is brought on by a shortage of iron in the body, has several symptoms, including exhaustion, shortness of breath, an increased risk of infection, and irregular heartbeat. Ketoacidosis is a condition that occurs when fat is utilized as fuel instead of sugar and carbs. This might lead to coma and death. This problem has been described by people who consume high-fat, very low-carb diets like the Atkins diet. Ketoacidosis may be brought on by starvation, severe vomiting, dehydration, high blood sugar, drunkenness, and diabetes. Since the kidneys serve as the body's filtration mechanism, an infection there has the potential to be fatal. The kidneys filter waste materials, manage acidity, and control how much water is in the body. Dehydration, infection, and conditions like low blood pressure increase the likelihood of kidney issues. Our bodies contain a built-in defense mechanism called lanugo to help keep us warm during times of hunger and deprivation. Our bodies develop fine hair as a protection mechanism against the cold. Similar factors may also cause transient eyelash thickening in people with eating problems. The inability of the liver to carry out its regular activities of filtering blood and digestion of food is known as liver disease. Lack of periods, extreme dehydration, or chronic heart failure are all risk factors for liver damage or failure. Hypotension, or low blood pressure, may result from starvation, a reduction in body temperature, malnutrition, and dehydration. Electric shock, irregular cardiac rhythms, and even death might result from this. Orthostatic hypotension may be present if your blood pressure rapidly lowers when you stand or sit up. Symptoms include intense headaches, dizziness, double vision, lightheadedness, fainting, and a racing heart. The majority of anorexics and some bulimics claim to constantly feel cold. Loss of muscle mass and body fat fuel this illness. The insulating layer of fat that usually keeps them warm has been worn away since they aren't eating enough. Low platelet counts may be caused by vitamin B12 and folic acid deficits, as well as frequent alcohol usage. One potential contributing factor is a compromised immune system that a person who is undernourished lacks the calories, protein, fat, carbohydrates, and/or other macro and/or micronutrients that their bodies need to function properly. Malnutrition is linked to serious health risks, such as respiratory infections, kidney failure, blindness, heart attacks, and death. The body uses its own stores of nutrients and energy, which causes muscle atrophy. Potassium deficiencies in particular have been related to a decline in neuromuscular function. Some patients even suffer brief paralysis, which is characterized by extreme muscle weakness and immobility. This can be caused by a deficiency of potassium in the body or by malnutrition-induced degeneration of brain or spinal cord nerve cells. If transitory paralysis lasts long enough, it might cause permanent muscle weakness or even death. Expansion of the salivary glands, or parotid glands, which are located behind the ear and behind the cheek. The person may have enlargement in both parotid glands after avoiding vomiting for a day or more. Seizures, due to conditions like dehydration, hyperglycemia, and ketoacidosis. Individuals with eating disorders like anorexia and bulimia may be more susceptible to seizures. Chronic hunger and a lack of oxygen-carrying cells in the brain are also likely causes. Tearing of the esophagus. Mallory-Weiss tears are microscopic rips in the esophagus caused by frequent, vigorous self-inflicted vomiting. People with eating disorders may often have difficulty falling or staying asleep. These and many more are some of the consequences of eating disorders. Chapter 4. Some causes of eating disorders. There is growing evidence demonstrating how diets, body size, and negative body image are all influenced by the media. According to studies, the rise in eating disorders is correlated with the frequency of media messages urging individuals to diet. Everywhere you go, thin women are idealized, whereas obese women are made fun of. A variety of predisposing circumstances must exist for an eating disorder to proceed to its full intensity. This includes psychological, genetic, biological, and cultural factors. The media encourages diets, despite the fact that it is a danger factor. The most insightful and compelling critique of the media's involvement in eating disorders today was presented by Ann Becker and her Harvard colleagues when they were researching the effects of television's introduction to the Fijian Islands. Prior to 1995, there was no television in Fiji, hence eating disorders and diets were not common. According to Ann Becker, losing weight was frowned upon in the 2,000-year-old Fijian culture, and if you did, your neighbors would come over to assist you gain weight. It was inconceivable to starve or vomit in order to reduce weight, and eating disorders were unheard of. Teenage girls started dieting only 3 months after television was introduced to the island, and by the third year, 11% of them were throwing up to reduce weight. Many Fijian women who responded to a study indicated they wanted to lose weight in order to become more socially acceptable. The Fiji research is one of the most important studies that has ever been done on the relationships between media, popular culture, and binge eating. Research into the probable biological origins of eating disorders is ongoing. Serotonin and dopamine may have a role in anorexia and bulimia, according to early research, although its specific mechanism of action and treatment options are yet unknown. Do eating disorders run in families? One possible risk factor for the emergence of an eating disorder is genetics. Recent years have seen the emergence of new data suggesting a genetic predisposition to developing an eating disorder. It has been shown that eating disorders have a hereditary component. There is a link between having an eating disorder yourself and having a family member with one. The risk is highest for individuals who have a first-degree relationship with the person, such as a mother or sister. Remember that only around 5 to 10% of people with eating disorders have relatives who also struggle with the condition. We are not just discussing genetic transfer here. Eating disorders may have a hereditary component, according to research, although there are complex interactions between environmental and genetic variables. Nobody is certain of the genes that are involved or how this is handed on from one generation to the next. It is unknown how much of the behaviors associated with eating disorders is learned. However, close relatives may also act as role models. The study of identical twins may be helpful in this situation. According to the findings, identical twins are more likely than their fraternal, non-identical counterparts to have an eating issue. Given that identical twins have the same genetic makeup, it is probable that genetics contributes to the explanation of why they are more prone to experience problems than their fraternal counterparts. The fact that identical twins have a greater frequency of eating disorders than their fraternal counterparts does provide evidence against the claim that eating disorders are purely genetically determined. Fraternal twins are less likely to interact with each other than identical twins, who are also treated identically. The limited amount of genetic studies that have been done to look for specific genes that increase the risk of having an eating disorder have not yet produced any conclusive evidence. There may be a hereditary component to the development of anxiety, compulsiveness, and perfectionism, all of which have been associated to the emergence of eating disorders. If 10 individuals decide to diet together, the most compulsive and idealistic one of them could get anorexia nervosa. It's possible that a person's genes have a part in determining their personality, which in turn affects their eating habits. Is it accurate to say that mental health problems may cause eating disorders? Many individuals who suffer from eating disorders also battle depression and anxiety. Lack of confidence and an obsession with one's looks seem to play a part. Bullying and other types of peer criticism over body image have both been connected to the pressure to be thin. In addition to many others, eating disorders have also been connected to problems with impulse control, mood management, perfectionism, obsession, and rejection sensitivity. Although not necessarily indicative of an eating disorder, these traits should be watched for since they are so prevalent in persons who have this condition. It is typical for dieting activities to grow into coping methods for an eating disorder. A person who is highly sensitive to rejection can try losing weight as a way to increase their chances of being loved and accepted. This may cause a vicious loop of, I'm upset, so I'm going to binge and purge. I blew it anyway, so I might as well eat everything I can since I'm going to purge. And I'm going to purge, so I might as well eat everything I can, up until the person has fully developed bulimia nervosa and is regularly participating in the behaviors on a daily basis. Binge eating is a behavior used by some individuals to cope with loneliness or isolation. Starvation and strict control may make some anorexics more comfortable, and this effect seems to have a biological basis. Abuse and eating disorders. Clinicians have known since the dawn of time that some people with eating problems also have a history of sexual abuse. It is clear that not all sex abuse victims would later have an eating disorder. Although the relationship between sexual abuse and eating disorders was previously unknown, current research has shown that PTSD caused by sexual abuse increases the risk of developing purging binge eating disorders like bulimia and anorexia. However, this seems to be less frequent than with PTSD. Pre-adolescent girls are more likely to experience body dissatisfaction due to family pressure to be thin than due to peer or media pressure. According to the annual review of eating disorders that in a large sample of teens, it was shown that parental dieting or encouragement of a child's weight loss might indirectly predict bad weight management habits. There is both direct and indirect familial impact. Direct family encouragement may help with weight reduction, exercise, and diet, even though she was not overweight by medical standards or anybody else's standards. Indirect parental modeling of eating disorders, diets, and weight fixation is also possible. I've seen mothers bring their kids in for eating disorder counseling, even if they themselves barely eat anything tangible for lunch. We already know that childhood sexual abuse is a risk factor, and research examining the association between eating disorders and attachment problems have shown that many individuals with eating disorders also had trouble developing good relationships as kids. Parents that put an excessive amount of emphasis on accomplishment and external approbation may have an impact on their children's value systems. Children may be more inclined to seek acceptance, admiration, and esteem via means related to their physical appearance if they are taught to base their self-worth on the views of others or encouraged to value themselves primarily on their accomplishments rather than their distinctive attributes. It's also worth noting that research has shown that family therapy is the most effective treatment for adolescents with anorexia nervosa, and that it could also be true for those with bulimia nervosa. This shows the importance of familia in helping teens deal with eating disorders. Chapter 5. Treatments for eating disorders. Therapists provide psychological therapy, addressing the patient's underlying issues, body image, and eating disorder symptoms. Either fully licensed professionals or interns with considerable training in the subject are required to treat people with eating disorders. They often work in outpatient settings and may see patients ranging from once a week to 4 times a week. Although sessions last between 45 minutes and an hour on average, some therapists may plan longer ones. Therapists use a variety of therapeutic techniques, with individual, group, and family therapy being the most common. Any of these methods may be used as part of a person's eating disorder treatment plan. The greatest medical assessment, monitoring, and therapy may be provided by a doctor who has expertise treating individuals with eating disorders. You must provide your doctor with a thorough description of your behaviors and symptoms before they can assist you. A thorough physical examination is required. Make a careful decision when choosing this person and be open and honest with your doctor. Additionally, the doctor has to assess your development and work with you and your therapy group to set objectives. Medical professionals who have undergone further training in the diagnosis and management of mental health disorders are known as psychiatrists. You may already be seeing a therapist and just need an examination and any required medication provided by your psychiatrist, since eating disorders are a growing area of specialization for psychiatrists. As an alternative, you can see a psychiatrist who both serves as a therapist and writes prescriptions for medication to treat your issue. Every situation is distinct, and various psychiatrists have different methods. You must choose depending on your own requirements. Meal preparation, calorie requirements, and body weight are just a few of the numerous issues that licensed dietitians and nutritionists deal with on a daily basis. Nutritionists that specialize in treating eating disorders are in great demand as a result of the growing demand for their services. The gold standard for treating eating problems are certified nutritionists who address problems with calorie consumption. Dietitians and nutritionists could assist you in creating a healthy eating plan. What is group therapy, and when should I think about it? Group therapy is very effective in treating eating disorders because it fosters a secure environment where people can open up and discuss their experiences without worrying about being judged. In a group situation, peers may compel you to consider your own attitudes and behaviors. I believe group therapy may benefit a patient unless they are really aggressive, ill, or distracted to the point where they cannot focus on listening to or sharing with others. It could be beneficial to check out other groups in the same approximate region if one specific group doesn't appear to be a good match for you. Talking and listening to others who understand their challenges may be therapeutic for many people who suffer from eating disorders. Even though everyone's experience with an eating disorder is different, many who battle this illness have several traits. One's feeling of self-worth may be significantly improved by just understanding that they are not crazy or alone. Since some people are more adept at managing certain circumstances than others, they help one another out. The drive to feel unique is another need that persons with eating disorders have in common. In order to stand out among their peers, members of an eating disorder support group must acquire good coping mechanisms. When treating young children, individual and family therapy may be more beneficial than group therapy. Does treatment for children and adults differ? Although solo treatment is more effective for adults, research revealed that family therapy is advised for teenagers. Adolescents face particular challenges, such as puberty, peer pressure at school, and navigating romantic relationships for the first time, which may make group therapy not an effective treatment option. Prozac can treat bulimia. Prozac is one of the only medications that has shown any promise in the treatment of eating problems. New research refutes the conventional wisdom that Prozac helps anorexics avoid relapse after weight gain. Prozac, an antidepressant, has been demonstrated in tests to help some people with bulimia, but it is not a panacea. Research indicates that Prozac is useless for at least half of bulimic patients, and many more still exhibit symptoms while feeling better. Furthermore, studies have shown that cognitive behavioral treatment is similarly beneficial. You may choose the most effective course of treatment by seeing a psychiatrist. Prozac has been shown to be useful in treating bulimia, as was previously mentioned. Studies show that it lessens binging and purging, albeit it hardly ever, maybe only 20% to 30% of the time, completely eradicates them. So yet, no research have shown an effective therapy for anorexia. Early research suggested that an antipsychotic drug, commonly known as Zyprexa, might be helpful in helping patients with anorexia gain weight and possibly in reducing obsessive-compulsive disorder. Individuals with anorexia lack serotonin, either due to starvation or possibly a biological deficit in this brain neurotransmitter. Do I need to see a nutritionist? The ideal person to assist with problems relating to food and weight may be a doctor or therapist who specializes in eating disorders. Your therapist, doctor, or other treatment professionals will have more time to focus on other facets of your care also. But if you believe that your doctor or therapist is unable to assist you with problems linked to food and weight, it might be helpful to find someone who can. A dietitian with experience in treating eating disorders may be a valuable addition to health professionals. Nutritional therapy and guidance may help eating disorder patients comprehend the physiological repercussions of their disordered eating patterns and get over the worries that go along with them. Most sufferers of eating disorders lack the ability to perceive their own hunger and fullness, their preferred meals, and what constitutes normal eating. You may break harmful eating behavior and habits like compulsive dieting, purging, and binging with the aid of specialist dietitians. They may also help you learn how to eat well, so you can avoid giving into binges brought on by hunger. A nutritionist could also suggest taking supplements like calcium, iron, or a multivitamin. The ultimate goal of a nutritionist is to assist you in developing lifelong healthy eating habits. Chapter 6. Treatment for Eating Disorders. Involuntary hospitalizations are challenging and should only be undertaken for adults in the most serious circumstances unless the patient is a kid. Residential, partial hospitalization/day treatment, intensive outpatient, and sober living facilities are just a few of the many various kinds of treatment facilities that are accessible. In order to stabilize a suicidal patient or address medical illnesses or eating disorder consequences, short-term hospitalization is often required. This might happen in a medical or psychiatric institution. A longer stay may be necessary if the patient's condition is severe. Residential care may be a useful choice for those who require or desire around-the-clock care, but aren't suicidal or physically unstable. These programs often include amenities not accessible in hospitals, such as grocery shopping, cooking, exercise, and other everyday activities. They are smaller, finer, more personal, and sometimes less expensive than hospital environments. Residential homes provide a broad range of levels of care, so it's important to thoroughly consider all of your alternatives. Intensive outpatient programs may be used in addition to routine outpatient therapy as a first step up in care or a step down for patients who have previously received more intensive treatment. These sections often meet once or twice a week during the day or at night for a brief amount of time. Depending on a client's health and the amount of time their insurance will pay for, the time they spend in treatment might vary greatly. Most courses require a stay of at least 1 month, although many patients want much longer. For some people, it can take many months. Chapter 7. CBT. The purpose of cognitive behavioral therapy, CBT, is to assist patients in identifying, assessing, and modifying false beliefs. CBT has been demonstrated to be successful in treating bulimics and binge eaters. However, anorexia nervosa has not yet been successfully treated with this strategy. The behavioral techniques used in cognitive behavioral therapy, CBT, seek to change a patient's thought patterns and conduct, as well as elicit their ideas about the significance of their actions. Cognitive behavioral treatment for eating disorders focuses on behaviors such as purging, restricting, and binge eating. In an attempt to promote more healthy ways of thinking and doing, negative body image attitudes are confronted head-on. Keeping track of eating behaviors, correcting false beliefs, and identifying relapse triggers are crucial parts of this therapy. The kind of CBT that has been shown successful via research often lasts for around 20 weeks and is quite focused. 3 separate stages exist. Low self-esteem, excessive concern for appearance and weight, and restrictive diets all contribute to bulimia's vicious cycle, which is addressed through behavioral approaches intended to replace binge eating with more stable eating habits in stage 1. The second stage entails moving away from dieting and towards a healthy lifestyle. The way a person thinks, his or her values, and the convictions that underlie their disordered eating are extensively examined. The last stage of CBT is concerned with maintaining the gains made during therapy after it has stopped. The gold standard for treating bulimia, in the opinion of many professionals, is cognitive behavioral therapy. This is due to research showing that CBT, as opposed to alternative treatments like medication and psychodynamic therapy, is more successful in reducing binge eating and purging behavior in bulimics. Binge eating disorder has also been successfully treated with CBT, and some patients have even reported being able to reduce weight as a result of the therapy. It should be stressed, nonetheless, that a significant percentage of people in trials using this therapy for bulimia continue to have symptoms after treatment stopped or relapsed. Other approaches, including IPT, may be just as successful, according to new findings. Therefore, it would seem that CBT works best when used in conjunction with other treatments. The little research on CBT's effectiveness in treating anorexia has produced a range of outcomes, hence more research is required. IPT. In spite of the fact that it was first developed in the 1940s to treat severe depression, it is now often used to treat addiction, marital conflict, and eating disorders like bulimia. IPT, which is non-directive, generally entails 20 sessions of 50 minutes, each spaced out over 4 to 5 months. Instead of focusing on specific eating and weight-related practices, this therapy primarily targets problems and conflicts in interpersonal relationships. The issues are identified by looking at 3 different types of data. 1. The interpersonal context in which the eating disorder first emerged and, more importantly, has been maintained. 2. The quality of the person's current interpersonal functioning. And 3. The interpersonal context of specific episodes of the eating disorder. In IPT, the primary emphasis of therapy is determined by the results of a thorough evaluation that culminates in the creation of an interpersonal inventory. Patients are made aware of the role that interpersonal relationships played in the development and maintenance of their symptoms. The first step of the therapy process, which consists of 3 stages, attempts to secure the patient's commitment to the procedure, identify urgent interpersonal relationship concerns, and establish a treatment plan. With the exception of the therapist exerting additional pressure for the client to change, the second and third phases of IPT for eating disorders are comparable to those of IPT for depression. Any efforts to treat the eating problem are deflected by the therapist to the interpersonal environment rather than being directly addressed. When contrasting IPT for eating disorders with CBT for bulimia, it was discovered that IPT patients fared exactly as well at the time of the follow-up examination, despite the fact that cognitive behavioral treatment, CBT, initially seemed to be more beneficial. Nobody had any idea that this would happen. Other studies have showed that IPT is equally as effective as cognitive behavioral therapy in assisting people with binge eating disorder to reduce their binges. DBT, dialectical behavioral therapy, DBT, created by Marsha Linehan, has been shown to be effective for persons with eating problems as well as those with borderline personality disorder. DBT is predicated on the notion that certain individuals react to emotional stimuli with particularly high levels of arousal and take longer to return to normal. Although the precise origins of these people's reactions are unclear, a combination of biological and environmental factors may be to blame. Emotional instability and difficulty with stressful events are more common in those with BPD and eating disorders, particularly bulimia. DBT is a highly focused therapeutic approach that imparts coping skills. Similar to CBT, DBT emphasizes on dealing with bulimia's behavioral symptoms head-on, including issues with impulse control, self-destructive habits, mood swings, and problematic interpersonal relationships. By concentrating on enhancing their interpersonal relationships, patients in dialectical behavior therapy, DBT, learn to control their emotions and resolve their problems without turning to destructive or unproductive behaviors. DBT is often described as combining cognitive behavioral therapy, CBT, and interpersonal therapy, IPT, and its effectiveness in treating eating disorders is anticipated to get greater attention in the coming years. DBT includes mindfulness and awareness training as well, which trains people to be more attuned to their environment and themselves. Is it possible to heal from eating disorders? Studies show that even though treatment could take a while, the majority of individuals with eating disorders may recover. Are eating disorders fatal? The majority of people who have eating disorders won't die as a direct consequence of their illness. However, eating problems are responsible for a significant death rate. Some individuals die from medical conditions, while others give up and murder themselves after suffering unrelentingly for so long. Anorexia nervosa has the greatest death rate of all mental diseases and is linked to a high risk of suicide. Girls between the ages of 15 and 24 have a mortality rate from anorexia nervosa that is 12 times higher than the death rate from all causes combined. A study published in the International Journal of Eating Disorders in 2000 indicated that longer illness duration, binging and purging, concurrent substance abuse, and concurrent affective disorders were all linked to death. Studies on the actual anorexia mortality rates vary, but between 5 and 10% of people with anorexia die within the first 10 years. Another 18 to 20% die within the second 20 years, and only 30 to 40% complete a full recovery, according to studies from the National Association of Anorexia Nervosa and Associated Disorders. Estimating the fatality rate for bulimia is much more difficult based on the statistics that are available. The evidence indicates that bulimia has a much lower death rate than anorexia. A 1997 study that appeared in the American Journal of Psychiatry estimated that the mortality risk for bulimia is about 0.3%. Data on the mortality rates of people with eating disorders not otherwise specified are not readily accessible. The fact that eating disorders are seldom listed as a cause of death when someone passes away makes it difficult to calculate mortality rates. Anorexia nervosa, or bulimia, may not appear on a death certificate, even if these eating disorders were the actual cause of death. Even though it is often misdiagnosed as heart failure, the eating disorder community is attempting to change the fact that bulimia nervosa is a primary cause of death. Anorexia nervosa is the hardest to overcome and recover from. Family therapy has been proven to have the greatest treatment results for adolescents, indicating that its use may enhance the current state of overall treatment outcomes. Remission often means being able to live a fairly normal life despite having a chronically low weight, obsessing over food and body image, and having irregular or no menstruation for the remaining one-third of patients. There are differences in the research, but the longer a person has had the ailment and the older they were when it started, the higher the probability that their treatment would be extensive and chronic with subpar outcomes. According to the preponderance of current data, 30 to 40% of persons with anorexia fully recover, 30 to 40% cycle in and out of treatment with a decent result, and 20 to 30% have a poor outcome. Remember that the precise figures will vary from study to study. The new family treatment for teenagers with anorexia, with an illness duration of less than 3 years, showed a comparable 80% recovery rate in the first year. In a UCLA long-term research, no one had completely recovered after 2 years, but by the 10-year point, 80% of the clients had. When properly managed, bulimia nervosa may be healed. Bulimic patients typically still suffer symptoms after treatment, but at a lower intensity. 75% to 85% of adult patients who get treatments for binge eating disorder, such as cognitive behavioral therapy, CBT, report significant symptom reduction right away. 2 other treatments that have shown potential are IPT and DBT. When it gets to the use of medication, we don't have enough data yet on teens. Researchers are now exploring the effectiveness of family therapy for adolescents with bulimia. Due to the high risk of recurrence, bulimic patients may need many sessions of treatment. According to several studies, around 50% of bulimics recover and remain recovered. Another 30% do so, but still exhibit symptoms, and 20% continue to fulfill all criteria after 10 years. How much time will I spend in therapy? The complete recovery from an eating disorder takes a lengthy period, 7 to 10 years, according to studies. But also in as little as a year, I have seen patients recover. Additionally, I've dealt with individuals who, even 10 or 15 years later, are still battling anorexia or bulimia. It is quite difficult to predict who will heal and how long it will take. Prepare yourself or a loved one for at least a few years of therapy. One typical mistake in treatment is leaving too soon. Chapter 8. Which non-medical methods are available to treat eating disorders? Some of the alternative therapies I've seen used to treat people with eating disorders include yoga, massage, acupuncture, meditation, homeopathy, and nutritional supplementation with vitamins, herbs, and minerals. Although many people have benefited from these therapies, none of them are recommended as the first or only line of treatment. According to a 2005 issue of Yoga Journal, the practice has gone from being considered as a new age fad to a multi-million-dollar industry. Yoga is a Hindu spiritual practice that aims to bring about enlightenment and mental peace. This discipline includes a series of physical exercises made to strengthen the mind-body connection. Yoga's asanas and rites are made to create a sense of oneness between the practitioner and the divine. It is well known that certain body postures are best for activities including digestion, relaxation, focus, and sleep. There are a number of positive qualities of yoga that have been researched and shown to be advantageous to one's physical and mental health. According to an online study published in Psychology of Women Quarterly, mind-body exercise, such as yoga, has been associated to better levels of body satisfaction and less symptoms of eating disorders than more traditional kinds of exercise, such as jogging or using cardio equipment. Additionally, frequent yoga practitioners were shown to have better attitudes towards their bodies, less tendency to objectify themselves, and less eating problems than non-practitioners. In fact, the more hours a woman engaged in aerobic exercise, the more likely she was to engage in disordered eating. But the more hours she practiced yoga each week, the less self-objectification there was and the greater the bodily pleasure. Yoga, in my view, enhances a person's bodily awareness and connection. Getting a massage is one way to start taking care of one's body. Following a massage, some people are able to let go of feelings they've been holding in their shoulders, backs, or stomachs. During massage sessions, people often feel comfortable expressing concerns they had shied away from in conventional therapy. Since touch is a touchy subject, getting a massage should always be an option. There are a number of things to take into account when determining how to include this into therapy. The massage therapist should be equipped to handle any unforeseen circumstances that may occur. Acupuncture. Acupuncture is a method for treating health issues by opening energy pathways. To do this, needles are placed into the skin at specific sites, known as acupuncture points. The first people to identify acupuncture points and devise a technique for placing needles in the body at specific locations was the ancient Chinese. I have seen effective use of acupuncture in treating anxiety, insomnia, cravings, and menstrual irregularities in patients with eating disorders. Homeopathy. In homeopathy, a patient receives very diluted versions of medications that, if administered in sufficient amounts, would have the opposite effect and lead to the symptoms of the condition. It is believed that homeopathic treatments activate the body's natural healing processes. Homeopathic anorexia or bulimia therapies may include taking drugs that stimulate the appetite or curb the urge to binge. All major religions have performed some type of meditation at some time in their history. It has long been regarded that the goal of meditation is to raise one's level of spiritual awareness via concentrated contemplation and introspection. Meditation is practiced by the mental or vocal repetition of a single word, phrase, or text, also known as a mantra, and is utilized in many religions. The technique of meditation extended beyond the boundaries of any one religion thanks to movements like transcendental meditation and others in the 20th century. The practice of meditation involves training the mind to slow down and concentrate on a single thing, such as the breath or a mantra, in order to silence the chattering of the ego mind. Even while meditation is often associated with religious practice, it is good for one's mental and spiritual development. Meditation helps people with eating disorder because it enables them to turn within, relax their brains, and develop more self-awareness. Learning to actively control your body's responses to stress may help those who battle with anxiety. Numerous studies have shown the benefits of meditation, which include inducing relaxation, lowering blood pressure and pulse rate, reducing anxiety, and lots more.